SpectrumMedics. Before we begin, I'd like to just go over a few housekeeping items. At the end of the webinar, there'll be a brief Q&A session. Feel free to enter your questions in the webinar control panel anytime during the presentation so we can address your questions at that time. Additionally, there'll be 2 short breaks during the presentation for poll questions. Please take the time to answer them as it helps us refine the webinars for the future and provide even more meaningful content. After the webinar, we will provide each attendee with a follow-up email containing highlights from the presentation. Now I'd like to introduce you to our 2 panelists for today. First, we have Dr. Raj Lakhanpal, who is the founder and CEO of SpectrumMedics. He is also a member of the HIMSS Clinical Business and Intelligence Committee. And prior to SpectrumMedics, he founded Health A to Z, an online wellness and population health management platform that assisted health plans and other clients in reducing their health care costs. Currently, he's also a member of the Board of Trustees of the University of Sciences in Philadelphia. And in addition, he's a fellow of the American College of Emergency Room Physicians and the Royal College of Physicians and Surgeons in the UK. Next, we have Mark Bryant. He's the Director of Sales with SpectrumMedics. He's responsible for new business development as well as client relations. Prior to joining SpectrumMedics, he was a senior account executive with both Sun Microsystems and Iron Mountain. Next, a quick review of the agenda. We'll start by detailing the requirements and deadlines for 2016 PQRS reporting. Next, we'll go into understanding VBPM, then preparing for the transition to MIPS in 2017. And finally, we'll take a deeper dive into the SpectrumMedics PQRS and MIPS solution. Without further delay, I'd like to introduce you to Dr. Lakhanpal.
Hello, everyone. Good morning. It's a pleasure to present to you. I'm Raj Lakhanpal. And as Mike had mentioned, we'll start with PQRS, advance to VBPM, and then talk about MIPS. So, I believe most of you will be aware of PQRS by now, or comfortable with PQRS. So for PQRS, you need to report on 9 measures across 3 domains. And the reporting deadline is 3/31/2017. But if you're reporting with ECQMs, then the deadline is end of February, so 2/28. You need to have at least 1 cross-cutting measure. And cross-cutting measures are those that span across multiple EPs. For example, influenza immunizations is a cross-cutting measure. BMI assessment is a cross-cutting measure. So different cross-cutting measures, you have to have at least 1 of those measures. And the reporting period is for the whole year, for entire 2016. So you need to begin planning now, or if you should have planned earlier, but you need to at least start now. Keep in mind that SpectrumMedics supports close to 170 PQRS measures, 23 measure groups, and all 64 EP ECQM. So through the electronic health record, if you want to calculate through ECQMs, we support that too. Also want to spend a little bit of time on measure groups. So measure groups are new, and what you can do is you can pick a measure group around diabetes. If you're a group of endocrinologists or primary care physicians, you can pick a measure group around diabetes. If you're an oncologist, there's a measure group around oncology. So CMS has made it easier for various different EPs to report via measure groups. So who must report in 2016? So all the physicians, all the MDs, DOs, podiatrists, optometrists, oral surgeons, all of those that were reporting earlier have to report. In addition to that, EPs need to report, and EPs would be physician assistants, nurse practitioners, clinical nurse specialists, certified nurse, registered nurse, anesthetists, and the list goes on. And then therapists need to report too. Essentially, anybody that's generating a Part B Medicare claim has to report. What are the different PQRS reporting options? You can either report individually as an individual EP, or you can report it as a group. So for an individual EP, keep in mind that then the reporting has to be for every EP separately. And there you can report via ECQMs, as we talked about, as I talked about earlier. You can report through a qualified registry, and then you can also report through a QCDR. And we are a qualified registry. Spectromedics is a qualified registry. Same thing with group reporting options. You can report as ECQM certified EHR technology. You can report through a qualified PQRS registry. You can report through a QCDR. You can also report through a GPro web interface, and that's what that's when you report directly to CMS. And for providers with greater than 100 EPs, 100 or greater, you also need to report patient satisfactions through a certified survey vendor. Now transitioning to VBPM, we are currently reporting for VBPM. So your PQRS scores will be applied towards VBPM. And VBPM is a value-based payment modifier. It's a cost-neutral program to CMS. So some EPs will either receive an incentive, and the others will be penalized. And the different components of VBPM are PQRS measures, are outcome measures, are patient satisfaction measures if you're greater than 100 EPs, and cost measures. And the cost measures, keep in mind that CMS provides you QR/UR reports twice a year, generally in the summer and the fall winter time frame. So you should be reviewing them to understand how you're performing vis-a-vis other providers in terms of costs. And out of this comes a quality of care composite score and a cost of care composite score. And the other than PQRS reporting, all other measures are available to CMS through the claims data that you provide. And based on that, so you can either receive an incentive or a penalty. The sure way to receive a penalty is not report for PQRS, and that will be 2% here. Depending on how you, or a neutral 2% penalty. Depending on how you perform, you can also receive an incentive. And if you are less than 10 EPs, you could receive a 1x or a 2x upward adjustment depending on your performance with all the 4 components. If you are 10 or greater EPs, you could receive a 2x or a 4x adjustment. Conversely, you could also get a 2% or a 4% penalty if you do not report PQRS and also do not do well on other components. So I hope that was clear. It's a little complicated, but I hope it was clear how that is done. So as I mentioned, we're currently PQRS applies towards VBPM, and this is the 2016 reporting period. It's applicable. The incentives and the penalties apply in 2018, and we talked of 2x, 4x, 2% or 4% penalties, and this says here it applies to everybody this year. So the keys to the PQRS reporting, keys to success in an ecosystem or in an environment where you're transitioning from PQRS to VBPM and then to MIPS. Some things we've learned over the past couple of years. I think as you look at PQRS measures, make sure that they're aligning with VBPM measures and also with meaningful use measures as well. Should choose your measures carefully. Make sure you take data availability into consideration, not as you collect the data and calculate the measures. Data availability with good data governance would be very critical as well. And then you should select measures where you feel that your EPs are performing well, because this will apply to your performance scores, your quality performance scores. So that's important, very important too. As I will show in the next couple of slides, there is a very significant financial incentive or penalties. So make sure that your teams, you have a team model where not only quality but IT and finance are also involved. Hold regular status meetings, and I think Mark Bryant will talk more about this slide. And you must start the process early. It's very, very important because you're learning how your EPs are performing, how they could perform over the next 6 months, over the next year or two. So start the process early, and also implement a system for ongoing quality improvement or ongoing quality improvement and performance improvement. So it should not be, let's do a one-time compliance reporting and get this out of the way. It's important for VBPM and MIPS that you are constantly improving the quality that your EPs deliver. So now transitioning to MIPS. There are 3 components of MIPS. The proposed rule is called MACRA, and that'll come into effect in November, and it'll be finalized in November timeframe. So things may change, and MIPS is the program under MACRA. So keep that in mind. So MIPS is a combination of PQRS, VBPM, as well as meeting. So all 3 have been combined into one program called MIPS. And MIPS stands for Merit-Based Incentive Payment System. So as I had mentioned earlier, the penalties or the incentives for VBPM for 2016 reporting, and the penalties or the incentives will apply in 2018, was 2 to 4% incentive and 2 to 4% penalty. MIPS starts next year. The proposed rule, once it's approved or it's finalized, starts next year, 2017. And the incentive for that is 4%, and the penalty is 4%. This will apply for 2019. It goes up to 9% in 2022 for incentive and 9% for penalty as well. And since, again, it's going to be a cost-neutral program to CMS, there is a potential for 3x adjustment. So EPs that perform very well could get up to a 12% incentive under MIPS in 2019. And the components of MIPS are the following. There are 4 categories. It's quality, it's resource use. Quality is your standard PQRS measures. The number of measures are proposed will go down, but these are standard PQRS measures. Resource use will be your, your cost of care, and then clinical practice improvement is based on milestones that CMS will place that you have to acknowledge, as well as it's based on interoperability, HIE adoption and interoperability. And then advancing care information is about meaningful use. The old meaningful use. And the components, quality is all PQRS, will be 50%. Cost in 2017 will be 10%. And clinical practice improvement, which is milestone-based, it is attestation in the proposed rule, it will be about 15%, and not about, will be 15%, and advancing care information is 25%. And advancing care information, as I mentioned earlier, is the old meaningful. These will change. The category weights will change. In 2017, its quality is 50%, so it's a very, very significant component. In 2018, it'll come down to 45%. In 2019, it comes down further to 30%. And costs will go up from 10% to 15% and then to 30%. So it's very important that you improve your quality and you look at how to be more cost effective as you provide care. And the penalties, again, penalties incentives plus minus 4% in 2019, going up to plus minus 9% in 2022. So I think I'm done with my segment of the presentation. I'm going to hand it over back to Mike.
Thank you very much, Dr. Lockenpaul. Now everybody will take a short break to answer our first poll question. And that question is, what is your biggest challenge to reporting PQRS measures in 2016? Let's take a minute. I'll launch the question right now. And I'll be right back with the results. Okay, everybody. It looks like the majority had said that the biggest challenge is successfully extracting and then validating data. Now I'd like to turn the presentation over to Mark Bryan.
Thank you, Mike, and I appreciate everyone's time again today for taking part in our webinar. For my portion, I'm going to be describing a little bit about who SpectraMedics is, what our solution offering is for PQRS and beyond into MIPS, and then what's the process for engaging with us to help you report in 2016 and beyond. So SpectraMedics, our mission is to help hospitals, health systems, provider organizations make the transition from fee-for-service to fee-for-value and risk-based models. And we do that in 3 ways. The first is data consolidation and extraction, and we heard out of that poll question that is a challenge, and I'll go through that in a little more depth. The second is our measure framework, reporting both hospital and ambulatory programs, and we'll focus today on PQRS. And the third is predictive modeling, and that's both for inpatient initiatives such as readmissions, value-based purchasing, length of stay, and also for population health around risk stratification, gaps in care, dynamic disease registries. We're not going to cover that today, but happy to speak to you separately on that if of interest. And then down below here is a select group of clients and relationships. Can certainly provide you this in more depth as well. But just taking a look at a couple. First, we're very proud of our relationship with Haney Solutions, which is a division of the Hospital Association in New York, where they've endorsed our PQRS solution. Through that relationship, we've been working with the greater Hudson Valley Health System and also with Auburn Community Hospital to report PQRS. The 2 in the middle with Mount Sinai and Staten Island, we're doing a lot of work around Medicaid reform in New York State underneath their program called Disrupt Delivery System Reform Incentive Payment Program. So for Mount Sinai, we're helping them not only with their Disrupt program, but also their clinically integrated network of 3,400 providers around measures for performance improvement. And with Staten Island, PPS, Performance Provider System, we're helping them with data consolidation from their partner organizations, measures reporting to maximize their incentives, and a lot around population health initiatives as well. And then we're also partners with Quantros, is distributing our ECQM solution, and Oracle as well. And so the next slide is talking about our measure framework. And down below you'll see that we can extract data from multiple sources, and in a couple slides coming up I'll speak specifically to that. But once we have the data, we can layer around that our measure framework to report on hospital programs. We're certified for all 29 hospital electronic clinical quality measures to help you support HIQR, Meaningful Use to Joint Commission. And then what's important to you today is we're certified for all 64 ambulatory ECQMs for PQRS and for Meaningful Use. And as Raj had stated earlier, we're also a qualified registry supporting 169 PQRS measures. But we can also help on other programs too. If you're part of an accountable care organization, if you're in a state with Medicaid reform, such as New York with Disrupt, if you're involved in any other pay-for-performance programs with your commercial payers, we can help build measures around those and to support it. We're part of a pilot program with NCQA. Last year, we were selected by them to help them develop EHEDIS measures. So we have significant competencies in being able to build measures and report for multiple programs. And so specifically for PQRS, as a qualified registry, we can support for individual reporting, we can report 64 ECQMs if you've chosen to report via electronic clinical quality measures. We can also support as a qualified registry 169 measures and 23 measure groups that Raj had described earlier. On the group side, on the GPRO side, we can support ECQMs along with the 169 PQRS measures. Measure groups that only apply to individual reporting. And then below is a link to our measures, the list of our 169 measures. They are on our website, and we can certainly provide this to you afterwards separately too. So how do we help you extract that data and be able to report for multiple programs? So there's three ways that we can ingest data. The first is in a structured format. And this would be such as a QRDA1 or a CCDA that was pulled from your EHR system and given to us in that method. The second would be if you couldn't create a structured file format out of your EHR, we can give you what's called our data specification file, which we'd understand which measures you're looking to report on for PQRS this year and tell you the elements that would be needed to calculate those measures. And then you'd provide us back some type of flat file that we would ingest. And then the third is we can build in, we can extract data directly from your EHR as well. And so once we have that data, we can layer our measure framework around it and then be able to provide you dashboards for performance improvement. And I'll show you a couple of screenshots of those. And then we would handle all the submission to the various reporting bodies. And so for this case, for CMS, we would handle the submission for the PQRS measures, but we can also support accountable care organization measures, clinically integrated network measures, TCPI as well for that. And so our portal that we would provide you is completely customizable, and we offer what we see as 4 key roles within the portal. The first is an executive role, and the executive would look at performance of your provider group, of your health system, of your ACO from a whole, and be able to see how your providers are performing as an aggregate and then drill down into the specific measures, the specific programs that you're looking to track. Accompanying that role is what we call an analyst role or an informaticist role. The analyst role would log in, be able to see your specific measures, in this case tied for PQRS, and be able to drill down into the patient-level details to see if there's any gaps in the data, any workflow issues, what are the reasons for any exceptions and exclusions that are causing poor performance on that measure. Tied to the analyst role is a submitter role. The submitter would be, and it could be the same person as the analyst, but we can segment that off if you wish. The submitter would go in this case, if you're reporting via qualified registry, would go in prior to the March 31st, 2017 deadline, select the measures that you're performing the best on for your providers, whether that's via group or individual, and create a report that would be given to us that we would then format to submit off to CMS. And they can log in at any time after that to pull the final report for compliance and audit reasons. And then we can also offer a provider portal. A provider portal the provider can see their particular patients from an aggregate as well, and then drill down for gaps in care, utilization. We could do provider scorecarding, disease registries off of that view as well. So we wanted to give you 2 snapshots of the portal. We don't have time within the webinar to show you. We're happy to demonstrate it separately at any time. But from an executive role perspective, up top, you'll see that you have a list of measures, in this case PQRS measures, and how they're performing. And so what we do is we set with you, upon implementation, 2 benchmarks, the benchmark per measure. The benchmarks might be a national or state average and also an internal target, and that's driving the color coding. So if you're outperforming both benchmarks, you'd be in green, underperforming one area in orange, underperforming both, you'd be in red. This is an easy way to come back into the system and see at a high level quickly how that you're doing and what's the performance of those measures. And then you'll be able to drill down into those measures to see some trending for that as well. And then below is the analyst role, and this is where you can really do your true performance improvement, is being able to log in and be able to see each of the measures that are tied to the program, how many patients are in the denominator, how many exclusions and exceptions are there, how many qualify for the numerator, and why. And the why part comes with drilling down into the patient level details to see what caused a patient to be excluded or an exception to that measure. It could be that there's data missing. If we're using just claims data, it could be that G-code needs to be populated in order to qualify that patient for the numerator. If it's clinical data, it could be that data is just missing, wasn't mapped in the EHR, or it could be that the patient was excluded for the right reasons. They didn't qualify for that particular measure. So we give you that type of reporting within this portal on an ongoing basis for you. And with that, I'm going to turn it back over quickly to Mike for our second and final poll question of the day.
Thank you, Mark. Our second question of the day is, what is your biggest concern with the upcoming change to MIPS? I'll give everybody a moment to answer, and we'll be right back. Okay, everybody, we're going to close the poll right now and share the results. It looks like your biggest concerns are the ability to collect the data necessary to report and the ability to prepare in time to begin measuring on January 1st. Now I'd like to turn it back to Mark. Thank you.
Thank you, Mike. So now I'm going to take a few moments to talk through our engagement process and spend a little bit more time on that ability to collect the right data. So we work with our clients up front before we jump into an implementation to understand what measures they wish to report on and how can we get the best data to report for that, whether we're using just claims data or if we're using clinical data as well. We'll walk you through the options to be able to extract that data and utilize it for your reporting. So again, we can take in structured data formats such as from a billing perspective, we can take your 837P, your providers, and utilize those. We could take in clinical data such as a QRDA1 or a CCDA to help with the populate the measures that way. We can also build that data specification file for you and help you run a separate query to populate the data elements needed. We could do intelligent chart abstraction, again using billing data we'll need to be able to populate, to get the G codes to populate the numerator, so we can work with you to get those codes, whether that's through web forms or other methodology. And the third is non-standard formats, such as giving us other types of, maybe it's a spreadsheets and other type of file uploads to get around any information that might be missing to properly calculate the measure. So we have a sophisticated team here through the kickoff that would work with you, understand these needs, run different scenarios with you, and figure out the best way to extract your data to calculate these measures. And so our process starts once we understand what the data sources are that we can get. We'll get a sample data from you and run what's called our readiness assessment. So through the readiness assessment, we'll use the sample data and we'll run it against the measures that are of interest for you and give you back a report up front, sort of what I showed you in the analyst role, where you can get the patient level details. We'll be giving you a report up front that has that type of information that says, A, can you get to at least 9 measures across the 3 domains, and B, how are they currently performing? So you can start to see what are the gaps, and you can start to do remediation prior to going into into the implementation phase. We think that's a tremendous value that we can provide up front and start working with you and getting ahead to find the right measures that apply to your providers, not only to today, but as you transition to other programs in the future. And so that timeline looks up front. There's the assessment with the remediation, if there's gaps in the data and in the measures that need to be addressed. At the same time as the remediation starts, we'll start implementing our portal, start training your team on using it. Then we'll go live before there's the final review and submission phase. So we'll go live on the portal, get you utilizing it, and then prior to submission, we'll allow you to go back in, look at those measures as that submitter role, and pick the right measures that are performing the best and you wish to submit on this year. And we'll provide ongoing support throughout this process, maintaining the portal, finding a schedule for ongoing data collection, whether that's biweekly, monthly, quarterly, whatever the best methodology is for your team, giving you a portal to do the ongoing performance improvement. We handle all the submission to CMS for PQRS, whether that's via ECQMs or via qualified registry. As there's changes, and we know with MIPS upcoming there's going to be changes, but as measures change, we handle all this measure specification upgrades, and then we handle the data integration upgrades as well. So we'll let you know if the new data needs to be imported in and how the best to tackle that, and we'll work with you hand in hand on that piece. And so leading into our final slides is we want to be your partner not only for PQRS but for MIPS in the future as well. With MIPS, we know that it's just at a proposed state, but from our understanding, we can support the quality measures, whether that's via a group or individual, and be able to submit that to CMS. We'll be able to support the cost and utilization analytics aspects. We'll be able to support the reporting for improvement milestones underneath the clinical practice improvement assessment, and we'll be able to support your initiatives for advancing care information to yield meaningful use as well. And so overall, again, just as a wrap-up, we can support over 200 measures, whether those are ECQMs and or PQRS measures via qualified registry. We can support multiple methodologies for reporting for PQRS today, whether that's ECQMs, group, value-based pyramid modifier measures, and via qualified registry. We can support if you have multiple TINs through your health system. We can customize our portal, be able to report for each of those TINs and give you back reporting individually for each of those. We'll provide the ongoing performance improvement, and we want to be your partner to not only help you PQRS today, but maximize incentives in the future with MIPS. And as we go through our question and answer phase upcoming, we will be providing you material back after this webinar, but one piece that if you wish to request is we just released a case study with our partner, Greater Hudson Valley Health System. where they described their experience in reporting for PQRS in 2015 and how we assisted them through that phase. So we're happy to provide that to you as well. My contact information will be up at the end, but hopefully this webinar has been informative and of value to you, and we'd love to speak to you separately, so you can reach out to me at any time, and me and my team will be happy to address your questions one-on-one. But with that, I'm going to turn it back over to Mike for our question and answer session for this webinar. So thank you for your time, and Mike.
Thank you, Mark and Dr. Lockenpaul. We received several excellent questions, and I'd like to also introduce you to Raj Ardeshna. He's a business analyst who specializes in PQRS, and he'll be here to answer your questions. Our first question is, will MACRA and MIPS apply to rural health clinics in 2017 or in the future? If so, where can I find the reference data?
Hi, everyone. That's actually a great question. CMS has released, kind of as part of the proposed rule, a section titled Flexibilities and Support for Small Practices. And within that documentation, there are a few exceptions that are proposed to be made for rural practices. Part of what that entails is fewer requirements for some of the MIPS categories, specifically the clinical practice improvement assessment. And CMS has also proposed a large budget to help support those rural practices, specifically in education, training, and technical assistance. And so if you find yourself that in that position where you're either a rural practice or a small practice, maybe with a low patient count, or just maybe even struggling to get the resources to deal with MIPS, reach out to CMS directly. Again, the documentation for CMS is called the Flexibilities and Support for Small Practices.
Thank you. The next question. When doing electronic submission for PQRS, do we need a cross-cutting measure?
No, for electronic submissions, cross-cutting measures are not necessary. Again, cross-cutting measures are primarily used for, they're required to be used for face-to-face encounters, and the cross-cutting measures, which is part of one of the 9 needed measures for reporting in PQRS, are those that could be broadly applicable to multiple EPs across multiple specialties.
Next, once I select SpectraMedics for 2016 PQRS reporting, when will we need to begin the process?
I think both Dr. Lockenpaul and Mark did a great job of answering that. We really want to start as soon as possible. Part of working with us is that we start with your readiness assessment and the measure selection. We look at what measures you can successfully report and also what possible gaps in care you might have. Again, it's not just about reporting and meeting the criteria, but really how well you perform and what we can do to improve your quality.
Next question, how does your solution help with improving data quality?
Sure. Well, part of our readiness assessment and being able to look at the denominator counts for some of the selected measures, we can look at if there were cases where certain clinical elements were not done, or certain procedures, or whatever the measure might be looking for, and it gives you an opportunity to go back and make those workflow changes and get your EPs to really promote certain activities to get those quality measures to even higher performance rates.
And finally, how does your pricing work?
I'll take that one. This is Mark Bryant. So our pricing is broken into 2 areas. There's one-time fees for the assessment and implementation, and then there's a per EP fee for the annual subscription fee as well.
Okay, everybody, I think that wraps it up. Thank you again for taking the time to attend the presentation, and we will be emailing you shortly with follow-up materials. Again, if you have any other questions or concerns, please contact Mark Bryant, and his contact information is right here. Thank you again, and have a great afternoon.